So another important topic is the management of diabetic retinopathy, but more importantly, you need to diagnose or screen these patients, bring them. That's one big challenge. Today we are only seeing the tip of the iceberg. We are not seeing the entire diabetic patients as such. Whatever numbers that are quoted is still 50% or undetected diabetes. So which means there's a a lot of patients that are out there, and you know today that the numbers are increasing very rapidly, and it's more so in a country like India. So which means the problem of if they are not identified early on, we are only going to treat patients who have advanced diabetic retinopathy, where the results are going to be much poorer. So 1 and 2 actually don't know that they need, they have diabetes or diabetic retinopathy. So why do we need tele-screening? What is the role of tele-screening? We all know the urban-rural divide. We also know the distribution of ophthalmologists to the number of to the population that is out there. And it is not just the retina specialists alone who will do the DR screening. It is the role of every single ophthalmologist, and not just ophthalmologists, but many other stakeholders who are involved in managing diabetic patients should be involved in this. So screening for diabetic retinopathy is the key, because as we all know, it's a very clear condition which can be diagnosed or screened for based on just fundus images, based on, it's a very clear markers are there to identify these patients. Of course, clinic-based, when a patient who comes into your clinic, is the most effective way. When you make a diagnosis of diabetic retinopathy, it's very comprehensive. We continue to do an outreach screening for diabetic retinopathy, just like how we go for comprehensive screening in the community. We work in the community with the local diabetologists or primary care physicians to group these patients, and our team would go and identify these. But this is still not enough so we work with the local physicians, they screen for diabetes and we screen for diabetic retinopathy. But this is not enough. We need to reach out to much higher, larger population. So what are the dynamics of screening? First is reaching the diabetic. Today we are not doing that because the diabetics with normal vision are not coming to the ophthalmologist. But they go to a diabetologist or a primary care physician for their diabetes. They go to the pharmacies to buy the medicines for diabetes. They go to labs to do their blood sugar testing. So these are opportunistic areas where you could do the screening. And then the second part of doing that is, once identifying the patient, who are the target population, then how do you evaluate these patients for diabetic retinopathy, evaluation of the fundus, and then reporting. Once you have done the fundus examination, how do you report? Who can do the reporting? Whether it's a non-ophthalmologist grader or an ophthalmologist. So tele-screening, as I mentioned, is definitely a way to move forward to identify these patients in an opportunistic way, because I said they are the first point of contact. The primary care physicians or the endocrinologists or diabetologists are the first point of contact, and they can do the screening using tele-screening, just like how you do a blood test, blood examinations. These patients can be screened for, just a fundus examination. They usually do their blood hemoglobin, HbA1c, all that test is being done. One more station is to get their fundus photos done, and then the patient gets the eye examined. So this is what I mentioned by fundus images being captured at these opportunistically. So we have been doing this for the last 20 years with multiple diabetic clinics or endocrinologist clinics, where the patient who's coming there, their fundus photo is taken by the technician. We train their technician, and they send an image through internet to our base hospital, where a retina specialist used to look at these images. We developed a software for grading these images. It's not an AI software, but a semi-automated software where you generate a report, and then we send it back to the diabetology clinic within about an hour or two, so that if the patient has any retinopathy, then they are referred to the ophthalmologist for further management. So there are three components to tele-screening. One is the hardware, fundus cameras, the software for reporting this, which I mentioned, like a semi-automated software that we had for grading, and then the telecommunication that is very essential part of this. So what has changed in the last 10 years? Recently we are all talking about so much about telescreening, especially for diabetic retinopathy. We started with using these VSAT, big mobile dish antennas with the mobile vans, thanks to ISRO. We used to go into the community of Shankar Netralia did and Arvind did, but this is all gone now because with our cell phones, the technology has become much better. So we used all possible technologies. We used an extended Wi-Fi from the University of Berkeley, where we put antennas to communicate with the different locations. Then we do these multiple dongles, and then now we have the broadband. So the tele density is definitely growing in our country. So we have all the opportunity to use this technology. And then, of course, all of you have seen the growth in the cameras that have been coming. They're like, small. We used to look at those big fundus cameras to so many of these cameras. Almost every session you will see somebody talking about these so-called using these small handle fundus cameras or even using these mobile phones for taking fundus pictures. So it has come to that. From this to this, it's become that easy. So those cameras are available. Earlier we used to shell out 10 lakhs to 12 lakhs to buy a camera. Today we don't need to do that. So it's very simple. But what is the problem here is you take the picture and then who grades these images? Having these trained graders also has not been easier. To get a retina specialist to do that is a waste of time, and the time delay that happens in this whole grading and all that. And then the inconsistency in grading. Between two ophthalmologists, there has been a difference in the grading the same image. One says it's moderate NPDR, the other person says severe NPDR or PDR. So that's a challenge. So we have been working with, both Rajiv and myself have been working with the Google's team since 2013 to work on developing these AI algorithms. And today at Arvind, we are using this in real time, where you just drag and drop an image, and then within a minute or less than a minute, this says whether it's a mild, moderate, severe, whether the image has got diabetic macular edema, to what extent this is present comes out as a report. And based on that, you advise the patient whether to go see an ophthalmologist or not. And you can wait for 3 months and then come back again for a checkup, or after 6 months, or if they have no retinopathy, an annual checkup. So today, in our process, which we have been doing for the last 2 decades, we have replaced the retina specialist or the grader with the AI tool. So in the last 1 year, we have been screening about close to 90,000 diabetic patients just using these telescreening, using these artificial intelligence. We are also going into the other, as I said, we don't miss any opportunity to screen these diabetic patients. We worked with the government to go to the primary health center where the diabetic patients would come to buy their medicines or get their medicines once a week. All the diabetic patients in the government PHCs, they would come once a week. So the primary health medical officer will not prescribe the medicine or dispense the medicine unless the patient had his fundus photo or DR screen. So this way we are ensuring that every sorry about that, every patient gets the DR screening done. That's fine, sir. No problem. Not a problem. Thank you. So what we call as opportunity screening, and this is the only way we can screen to all those patients who are in the lower economic group, who would not, they with the normal fundus, with the normal vision, they are not going to go to the ophthalmologist. So you have to catch them when they have diabetes, all, in an opportunistic way. Wherever they come, you screen them for diabetic retinopathy. But what has not changed? Again, still there is poor awareness about diabetes and the diabetic complications. Many people, even educated people, however, you tell them that you need, diabetic retinopathy evaluation, but people don't do it because they always say, I can read even the smallest of letters, though I have diabetes for 20 years. They don't want to, this thing. Then also access to care is limited. Then, of course, myths about treatment and the absence of treatment is added to this. So the DR screening challenges, who should do the screening? People think it is the role of ophthalmologist, but I say I've been talking or promoting that the onus of doing the screening should be with the physicians, primary care physicians, endocrinologists, diabetologists, even the labs, wherever it is possible, because that is where your target population is going. They're not coming to the ophthalmologist. They come to the ophthalmologist only when they have an eye problem. So if we could screen these patients using technology, we'll be doing a great, benefit or favor to the diabetic patients. Like one of the group in Chennai had developed an innovative business model using this DR screening, where they worked with, put fundus cameras in multiple diabetic diabetology clinics all over India, and they used to screen about 15 to 20,000 diabetic patients every single month. It was a business model, so everybody in this gets to pay, but the benefit is that every diabetic patient is getting screened. So the AI algorithms, today you have a huge number of AI algorithms that are out there in the market. Some are certified, some are not certified. But what it means, what I'm trying to tell you is, AI is out there to stay, not just for diabetic retinopathy, it's going to come for glaucoma, AMD, and many other conditions. So the onus of finding the DR cases should be with the general physician and diabetologist, and the ophthalmologist should work with the physicians in completing the loop for identification. It's not enough if you just screen the patient and leave them. You have to find ways. The diabetologist or the primary care physician finds a case of diabetic retinopathy, they should know when to refer the patient and where to refer the patient. So we need to complete the loop, and use of technology and the AI will play a major role in early identification of these patients. Thank you again, sir, for this.
Yeah. Thank you, Dr. Kim. Any questions on this topic? Please. Yes, sir. Yes, sir.
Thank you, Dr. Kim. I wanted to know that the AI, deep learning you are using, the statistical data, where from you collected? From your own hospital, the software you made yourself, or taking from outside? Because their data may not be equal to the Indian.
Yeah, this was done on the Indian population, sir. What Shankar Netralia and Arvind did was we worked with the Google team to develop the algorithm.
Yeah.
But today, we have also noticed that there is no difference in the Caucasians versus Indian eyes, because they all have almost the same this thing, but there have been a lot of validation studies have been done. And before we brought it in real time, we did multiple validation studies before we deployed it in in our community. A validation study at Arvind we did across using different cameras and doing all that.
You mentioned that it is about 90% correct.
More than 90%,
More than 90%.
sir. Yes, sir.
I think it is going to stay.
Yeah, definitely it will be the way to screen the patients.